Good afternoon. I'm Linda Baker, the Learning Director for the Center for Research and Education on Violence Against Women and Children. On behalf of the Knowledge Hub team, welcome to our research briefing on the STEP program, intervening during pregnancy with women who experience childhood trauma to support well-being and mitigate the intergenerational repercussions of trauma. Our presenter, Dr. Nicolas Berthelot, will present the research briefing in both English and French. The English presentation will be followed by the French presentation. For both presentations, Dr. Berthelot will speak for about 15 minutes. Please enter comments or questions for the presenter into slido.com and use the code 7423. That code will be shown on the slides for your reference throughout the presentation. During the last 5 minutes of our research briefing, we will present some of your questions to our presenter for his response. The link to the presentation slides was emailed to you earlier this morning. Our distinguished presenter is Dr. Berthelot, a clinical psychologist and professor at the Université du Québec à Trois-Rivières. He holds the Canada Research Chair on Developmental Trauma, and he recently developed the STEP program, supporting the transition to and engagement in parenthood. And Dr. Berthelot is going to share more about STEP right now. Over to you, Nicholas.
Thank you very much, Linda. It's a great pleasure to be with you all this afternoon. So, as Linda just said, our team of clinician researchers at the Université du Québec à Trois-Rivières is interested in the way mothers who experience trauma during their childhood, how they experience pregnancy, childbirth, and motherhood. So the first reason we're interested in pregnant women who experience trauma is the fact that it's a very frequent phenomenon. We questioned more than 3,000 women in the province of Quebec, representative community sample, and 34% of them, so it's more than a third of them, reported that they experienced some kind of childhood maltreatment during their childhood. And when we looked at high-risk pregnant women, because they were under the poverty level or at the limited education, it's more than 60% of them who report childhood maltreatment. So that means that each year among the G7 nations is approximately 2.4 million children that are born to a mother who experience childhood maltreatment. So these numbers are alarming, even more so when we know that pregnant women who experience childhood trauma are at higher risk of maternal psychopathology, of systemic inflammation that may bear consequences for the developing fetus. Their placenta express more stress hormones. They are at high risk of intimate partner violence and of poorer maternal confidence and antenatal attachment. We also know that the experience of childhood maltreatment may have intergenerational repercussions, and we see that in two ways. First, there is that documented phenomenon of intergenerational continuity of childhood maltreatment. So I won't go into too much details, but you see through analysis or metasynthesis showing that offspring of parents exposed to childhood maltreatment will be around 3 times more likely than offspring of non-exposed parents to experience maltreatment. And even when there's no continuity of maltreatment across generation, we also know that childhood trauma may bear intergenerational impacts, since offsprings of mother exposed to childhood maltreatment will be at increased risk of psychopathology, of developmental delays, of disorganized attachment. They are at increased risk of abnormal brain development, having challenging temperament, having health problem, or even neurodevelopmental disorders. So these are the kind of data that have led some people to say that developing and evaluating perinatal intervention with parents exposed to childhood trauma seems to be a challenging priority, even more so since there are very few prenatal intervention that has been specifically developed for pregnant women who experience such trauma. So with the support from the Public Health Agency of Canada, we developed such an intervention during the last years. It's called STEP for Supporting Transition to and Engagement in Parenthood. So the program was developed and evaluated in 9 successive phases, as described in this figure. So what we did with 2 colleagues who are clinical psychologists, namely colleagues who's Christine Douai-Maziad, you'll meet her later today. We reviewed existing evidence regarding the impacts of childhood trauma during the perinatal period and identify a preliminary list of 36 actions that we thought were relevant to achieve for pregnant women having experienced childhood trauma. Then we present these actions to 15 stakeholders representing 9 different healthcare and community organizations working with survivors of trauma. And we invite them to participate to a Delphi consensus process during which they code how important they consider each pre-identified action and whether they were already conducting similar intervention in their clinical settings. So that permit us to refine what the intervention should look like. And 2 central clusters of action were identified in the course of this consultation process, namely actions to support mentalization about self and parenthood, and action aiming to support mentalization of trauma. So this consultation process was complemented by semi-structured interview with 10 parents who identified themselves as having a history of childhood maltreatment. So these parents further clarified their needs and state that they would have greatly appreciated having the opportunity to participate in a trauma-informed group accompaniment program during pregnancy. So then we developed our intervention and went on with the second expert consultation to make sure that what we developed was sound and was trauma sensitive. And after that, we present the manual of the intervention to parents who further comments on what we developed and went on with the pilot intervention. So what is STEP? Broadly, STEP is a manualized program. It includes between 8 and 9 sessions, depending whether if we offer it in person or online. It's intended for pregnant women exposed to childhood trauma, including but not limited to childhood maltreatment, intended to pregnant women who are experiencing psychological distress, or even pregnant women who do not report any psychosocial problems. As I said, it was designed to be offered face-to-face, but we had to adapt during the COVID-19 pandemic and offer the program online. And we said that STEP is an accompaniment program since we share information, we animate reflective activities, we facilitate exchanges, and we focus mainly on the here and now. But it's definitely not psychotherapy since we're not bringing participants to re-expose themselves in imagination to past trauma. It's not the support group neither, since we have activities that are pre-programmed, and it's not the parental education program neither, since we're not saying to participants how they should behave as mothers, and we're not teaching parenting skills. It's not the main goal of the intervention. So the program is divided into 3 sections. The first section is entitled Becoming a Mother. So in this part of the program, we aim to explore and normalize the emotion experienced by the participants in the course of their pregnancy and to support the use of healthy emotion regulation strategies. The second section, entitled A Look at My Own Emotions, aims to support mentalization of trauma by discussing the nature of trauma and its impact, by validating the participants' feeling as understandable responses to trauma, by supporting a reflection on positive and harsh experiences with significant others, and the way both types of experiences have influenced their current mental states and behaviors, and by identifying how participants cope with trauma. In the last section, entitled Looking Ahead, we aim to explore participants' needs and strengths, to present available resources to support resilience, and to provide the opportunity to envision positive and challenging moments with the child. So the entire activities of the program has been illustrated to facilitate reflection and discussions. So you see here some illustration we use in the course of the intervention. For instance, at the upper left, we have an illustration we use to discuss how mothers express of how they feel when they have experiencing difficult life events, and what is it like for her when they are experiencing psychological distress. You see another images on the right illustrating how harsh experiences and positive experiences may influence the way we perceive ourselves or even perceive and interpret infant behavior. At the bottom left, you see an image we use, one of the images we use to discuss how participants protect themselves from harsh experiences. And now it's been probably salutary for them, it's been helpful for them, but how at the point of being a mother, they should think of using other ways to face difficult life experiences. So we present our program to a panel of 6 experts with complementary expertises, and we ask them to evaluate using a 10-point Likert scale whether they found the program as being relevant and all of the activities to be relevant and to be trauma-informed. So you see on this graph that all of the activities were rated by the experts before we went on to offer the program to pregnant mothers as highly susceptible to reach their target, and all of activities were evaluated as trauma sensitive and sufficiently safe to be offered to pregnant women. Then we offered the program to about 30 pregnant women. At the time of computing the data, only 21 of them had completed the program. After each session, we asked them to rate their satisfaction. And you see that all over the 9 sessions of the program, they consider having learned things. They consider that all of the sessions helped them to realize things about them that they were not conscious of. They found all of the session useful. They did not find the session too emotionally challenging, even the sessions that were discussing past trauma. In fact, the level of emotional arousal in our perception was optimal, meaning that it was not too low, neither too high. And their motivation to participate to the next session was high from the beginning to the end of the program. Also, our preliminary data suggests that STEP help in regard to psychological distress. So the level of distress strongly diminished between the beginning of the program and the end of the program. So the next step will be to compare this with pregnant women who did not participate to STEP. So overall, participants report having really benefit from the program. You see 2 examples here. A mother saying that the session has been a striking experience, saying that she needed to go through different stages and reflection to welcome her baby properly, and she's been very grateful for to the facilitators for that. Another woman said that the program changed her life, that it has been a huge impact on her since it gave her the possibility to discuss and think about her experience. She even said that the relationship with her older daughter and her sense of responsibility as a mother has completely changed during the program, and she's also deeply grateful to the program facilitators and to the other participants. So overall, I think that we can say that STEP has a good level of acceptability according to experts and according to participants. It's one of the very first prenatal group interventions specifically designed for pregnant women who experience trauma. Fortunately, we observed that when doing so in a trauma-sensitive manner, it doesn't cause harm and it has benefits. And it may contribute to diminished psychological distress in pregnant women. So I think that's very promising. So before ending, just want to thank my team, especially Dr. Roxane Lemieux, Dr. Christine Drouin-Madiad, and Julia Garon-Bissonnette, who's been strongly involved in this program. All our partners in the community, as well as the Public Health Agency for their important support.
Thank you. I want to move right into some questions with the time that we have remaining, and well done for presenting in the time we allowed you, Dr. Berthelot, because it's a very short time. One of the things, as you show us these really promising findings, and I know there'll be great eagerness amongst all when you compare it to other women who didn't have the program, that next step that you spoke of. But what about dads?
That's a very good question, Linda. Thank you. We want to have a different program for that. In fact, when we conduct that consultation with experts at the very beginning, we had experts on fatherhood and organization working with fathers. And one of the conclusion of that full day in-person discussion meeting was that we needed to do a different intervention for men. We did not want to have partners involved in the program, since changes in the couple relationship during pregnancy is one important subject in itself, and we didn't have the time to include that whole reflection during the program, and wanted women to have the opportunity to share about very intimate things that maybe they did not share with their partner. But we will have another program for fathers, and we are developing it right now. It should be offered probably from here to 1 year in front of us.
It makes so much sense what you're saying about there's things that you might want to discuss outside of the partnership. And you created the safe space for that to happen. But we will look forward to the program for dads as well. One of the other things that you talked about this being a manualized, and our understanding is there are very few manualized programs that are to support women in this way. And one of the questions is, what do you see in the future? Is this the type of manualized program that can just be picked up and implemented if it should roll out? Or do you see specialized training for the potential facilitators who would use this manualized program? So maybe just some comments, Nicholas, on what you see about the future in terms of this program if everything keeps coming up with such positive results as you've had to date.
Yeah, I think the manual is very important in the training of new facilitators, and it's very helpful for facilitators to offer the activities. But it's not a training in itself. We definitely need a more specialized teaching and training about the program. What we do so far is that we have about 5 hours theoretical presentations about important concepts. Then we ask facilitators to follow a whole group, whether in person or to view the caption of that full group. And then when they will be offering their first group by themselves, we have a weekly 2 hours discussion to follow up the adherence and their experience of the program. So the manual is very helpful. The manuals are very helpful, but they are not a training in themselves.
That's such an important point, isn't it? It's a tool, but not to replace the training that allows someone to facilitate. One of the other questions that I think is really, we would like to hear you speak to in our last remaining minute or so is, we know that mothers who've experienced child maltreatment or traumas in their childhood and are about to become mothers or mothers again, we know it's not a homogenous group. So, are there some members of this group that might not respond to this treatment, or it may not be a good fit? And what would be your thoughts about that at this stage of the development of the program?
That is something we will be following and studying during the next months. So far, it's very interesting. Some people very benefit from the program, even though they do not express clinically significant distress at the beginning. We have some women who participate who are doctors, psychologists, social workers, and they really benefit from the program, even though they are people really involved in motherhood, who have a positive relationship with their partner and very few risk factors. They really benefit from the program. And we have other people who have an accumulation of risk factors and also benefit in a different way from other participants, but also benefit from the program. So far, I think that the program can be offered to wide array of profiles. It's maybe only people who are at very high risk of seeing their child under protection agency right after birth, or that kind of situation, that we are not ready to offer the program at this moment. We have one participant who we had to exclude from the program because she had a really, really severe personality disorder and was hostile in the sessions, but that's the only such situation we had to exclude someone. So far, um, it's interesting. We'll study if there are patterns or profiles that do not respond to the program properly in the next few months.
Right. Again, we're looking forward to all of those future results, and I can't thank you enough and your team for the work that they've done in developing this program and sharing the results. And we really will follow eagerly to see the future findings.